Thank you very much. My name is Ezekiel Oburu. I am an orthopedic surgeon at the University of Nairobi, and our topic of today is open fractures. Welcome again to our podcast today, where we'll be considering open fractures. Open fractures are a very important topic in orthopedics, especially in the area that I work in, which is Nairobi, Kenya, because they constitute a large number of patients that we see and admit in the orthopedic wards. Now, there are certain principles that are important in the management of open fractures. Number one, we want an accurate diagnosis and documentation of the mechanism of injury. Number two, we want coverage of the wound in conjunction with administering antibiotics and tetanus prophylaxis. And number three, we want to take the patient to theater and perform the necessary debridement, stabilize the wound, and prepare the patient for definitive fixation. Now, like all patients, when a patient presents with an open fracture, there are certain things that are critical. We want to ensure that we follow the ATLS protocol because the fracture may look quite gross and scary. However, there may be other more urgent injuries that the patient may present with. If this is an isolated fracture, though, what you want to do is to take a history of the patient to determine what is the location that the patient sustained the injury and what is the circumstance, what's the mechanism of injury. This will have a bearing towards the management. And then you want to proceed to do a physical examination of the patient. An accurate assessment of the wound is done in theater. Suffice it to say that I will mention the classification of the wounds right now. Now, in 1976, Gustillo and Anderson published a classification that really has stood the test of time. In the classification, they had three types of wounds. Number one is a fracture with a wound that is less than 1 centimeter in length and is clean. Number two, that is type 2, which is a fracture with a laceration that's more than 1 centimeter in length without extensive soft tissue damage, flaps or avulsions. And Gustillo type 3 is either an open segmental fracture or an open fracture with extensive soft tissue damage or traumatic amputation. However, this was added in 1984, where Gustillo et al. Subsequently added a subclassification of type 3. Type 3A is where you have severe comminution or segmental fractures, but adequate coverage of the bone. But type 2 is where you have extensive soft tissue damage with associated periosteal stripping, and type 3 where you have an open fracture with an arterial injury. Now, what are some of the important things that you may proceed with a patient who comes with an open fracture? I think that there's certain things that maybe medical officers or medical students miss when they think about open fractures because they readily proceed to the surgical aspects of these fractures. But I think that the important things that one can do that may prevent infection or subsequent complications that the patient may develop without necessarily thinking about surgery first. When you see a patient with an open fracture, the first thing that you want to do is to cover the wound. But prior to covering the wound, you need to take a picture of the wound. And this is important because you do not want you don't want other medical personnel coming to check at the wound, by opening the dressing. This further increases the risk of contamination. So you want to ensure that you cover the wound. And in the era of digital photographs, this is quite easy. After that, you can then cover the wound with sterile moist gauze. There is this practice that I have seen or I've heard in some settings where people irrigate the wound in the A&E department, but I think that this is really not necessary. I think as much as possible we should aim to take the patient to theater at the appropriate time, and the irrigation of wound in the A&E department will not necessarily help. The next thing that you want to do is to give tetanus prophylaxis, and this can be in the form of a toxoid or immunoglobulin. I mean, there are parameters which you will give, the toxoid or the immunoglobulin. In our setup, though, sometimes adequate records for the patients may be sparse, and I think that it is not unreasonable to give both. And then you also want to look at antibiotic treatment. Now, the antibiotic treatment of the patient will depend on the classification of the wound. Usually in patients with Gustilo 1, the antibiotic that we use is cephalosporin. This can be even second generation cephalosporin, but patients with type 2 and type 3 injuries will need an adequate gram-negative coverage in the form of an aminoglycosides. If we suspect that the patient has got an aerobic infection due to the mechanism of injury, for example, if it is a farmyard injury, then we may add a penicillin to cover the anaerobes. Don't forget that the patient will need adequate analgesia, and then they will need a splintage of the fracture to prevent further soft tissue damage, and taking the patient for an x-ray. After this, really, the next step is to take the patient to the operating room. There is debate as to whether or not the patient should be taken within 6 hours or 24 hours. Certainly when I was in training, the teaching was that the patient should go to theater within 6 hours. And I usually advise my medical students or medical officers that really you should try and take the patient to theater as soon as you can. There is one caveat to this, because you could find that the patient is being taken to theater in the middle of the night, where the staff or the personnel that will be dealing with the patient is relatively inexperienced and the equipment may not be there. It may therefore be advisable that you wait for another few hours, and it's reasonable to take the patient to theater within 24 hours when you have got the right equipment, the right personnel, and any help that may be available. So when the patient is in theater, what are the things that you need to do? Practically, one of the most important things is to debride the wound, to irrigate the wound as much as possible, even prior to debridement. Well, maybe irrigation is indeed part of the debridement process. Now, originally what was described is copious amounts of saline, up to 10 liters of saline, and I think that this still holds by and large true for a number of wounds. However, we work in an area which is resource limited, and I would not necessarily advise that we do copious amounts of saline in a place which is very resource limited. What I usually advise the medical students is wash this with tap water. Take as much tap water as possible and use it to irrigate as much as possible. Once you've washed with tap water and you've given really a social skin wash of the wound and the skin surrounding, then during a debridement you can use some normal saline, and this will reduce the amount of normal saline that you will need. Now, debridement really should be sequential and should be orderly. The first thing is you want to debride the skin. Um, Most times, especially with inexperienced doctors or surgeons, there is a great fear of debriding as much skin as possible, especially within the zone of injury. However, this dead skin or skin that's severely injured, should be debrided, because eventually it becomes necrotic. So that certainly has been my experience, that sometimes we leave skin which we see is questionable, and then eventually what happens is that the skin becomes necrotic, and this increases infection. After debriding the skin, one needs to debride the subcutaneous tissues that is necrotic, the dead muscles, and also the bone. The bone is another controversial area. Sometimes, as a surgeon, especially an experienced surgeon, you're a medical officer, you're working in whatever hospital, and you may not have as much supervision, you fear removing the bone which is dead. And, there's this temptation to leave a bone which is even hanging by a thread, of soft tissue, uh, you know, um, with fears that you may not be able to get healing if you remove the bone. But any bone that's hanging by its thread, or any bone that's loose, is really dead. It has no vascular supply, and it makes no sense to leave it. I think the most important thing is to get anything that you deem suspicious that may be dead, and then think about how you can get bony healing after that. And there's certain modern methods that can enable you to get adequate bone healing, even with significant bone loss. The next thing that you want to do is to stabilize the fracture, and there are various devices that you can use to stabilize the fracture. Initially, I think what was advocated was the use of an external fixation for most of these wounds, but studies have shown that you can actually even fix these fractures primarily, especially Gustilo 1 and Gustilo 2, and even some Gustilo 3A, because external fixators are very useful in the treatment of these fractures. One has to be careful, really. External fixators should be used in the minimum amount of time in order to avoid complications like pin track infections and non-unions. And you want to really replace the external fixator with a definite fixation method. What about the wound? What do you do with the wound? Now, initially, what was advocated was that all of these wounds should be left open. But I think current studies have shown that some wounds can be closed primarily, and this will reduce the time of recovery of the patient. That not all wounds have to be delayed in closure, but one has to make a judgment. We can have wounds which are quite extensive, with significant injuries or significant contamination, and these do not have to be closed primarily, but you can have delayed wound closure. But I think to say that all wounds have to be closed, or all wounds have to be left open, and you have secondary closure or delayed primary closure of the wounds, is not the current practice in many places. Significant with wound management is negative pressure wound therapy, and this has significantly changed the management of wounds, especially with regards to open fractures. Negative pressure wound therapy prevents colonization, gets rid of any of the discharge or the effluent that may come from the open fracture, and also encourage granulation tissue. So this may reduce the number of patients who may need complicated procedures like flaps. Suffice it to say that I think a decision as to how one will proceed with regards to wound closure is adequate. You want to get your wound closure as soon as you can. Always remember that the best dressing of any wound is the patient's skin. So you want to try as much as possible to involve the plastic surgery team. If you have Agustilo 3B, where you have periosseous stripping, the patient may require a flap, and therefore it's good to involve the plastic team very early. Then finally, it's important that you have a second look of the patient after 48 to 72 hours, just to ensure that the wound remains clean and viable. Like I said, if you need to do a skin graft or if you need to do a flap, this can be done early. Please ensure that you don't leave your wounds for open too long, and also you don't leave the external fixator for a very long period. There are other adjuncts that are useful in the management of open fractures. For example, you can have antibiotic impregnated bone cement, and this may reduce the rate of infection. So there are a number of things with open fractures that we have had a look at today. Obviously, this is a massive topic, but I have essentially gone through the basic principles. We want to ensure that the patient gets as few complications as possible, because one of the major complications of this injury is infection. Thank you very much, and see you next time for another edition.